Hi, my name is Nicole Hackley, and I am thrilled that you've taken time out of your schedule to learn more about the 6 CSAP strategies. I am a certified substance abuse prevention specialist in Montana. My career in prevention started in 2009 in the eastern Montana county of Richland, where I ran a family resource center under the Montana Children's Trust Fund grant. That expanded into substance use prevention under a variety of federal and state grants over the next 9 years, spanning 12 counties in northeast Montana. In 2017, I started my own grant consulting business for the behavioral health field, which I currently do more as a side job. But since 2019, I started with Youth Connections, which is based out of Helena, as the Eastern Regional Technical Assistance Leader. In that role, I trained and provided assistance to substance use prevention specialists in the Eastern Health Planning region. In 2021, I took on a new role within Youth Connections as the Workforce Development Coordinator, where I help plan and coordinate training and education opportunities for the prevention workforce to make sure prevention specialists are provided an opportunity to increase their skills and knowledge within the prevention core competencies. I am also a trainer for the Substance Abuse Prevention Skills Training, which is known as SAPS. It goes under the new name of SPF Application for Prevention Success Training. And I'm also an Ethics in Prevention trainer and a trainer for SAMHSA's Prevention Core Competencies. Some people who take this course already have an understanding that primary prevention is a science and might have possibly even learned about that science already. If you're new to prevention, this course will serve as a good base for some of that foundational prevention knowledge. And if you've been around prevention for a while, this course should be a good refresher for you. In my time as a prevention specialist, and still even to this day, I find that I can always get caught up in the day-to-day operations of my activities, but courses like this are very refreshing in that they help bring us back to the high level of understanding of the how and why prevention operates the way it does. So as we go through this training, we'll look at the how question of how we are going to reduce substance use rates. So to do that, we're going to go over our learning objectives, which you can see on the screen. We want to, again, look at that theory behind primary prevention strategies, define what these prevention strategies are and the corresponding activities that come with them. And also, my favorite part is looking at the strategies at the individual and environmental levels and working them all together to make the best and most significant impact. To do that, we're going to look at 3 different sections for this training. The first section is going to be more about the background of prevention science, and each section will build on that. So in order to understand how the strategies work effectively together, we need to first understand the science behind their functioning, what each of them are, and why certain activities are placed with specific strategies. So again, on section 2, we're looking at those strategies and activity definitions, and then section 3, using those strategies effectively together. We'll start with section 1, which is background and foundational knowledge, and provides a lot of information that we'll use to build on in each of the following sections. As mentioned previously, this section will focus on the very basic and foundational knowledge that prevention is a science and what that phrase means as it relates to the CSAP strategies. We'll move into the definition of primary prevention and how that is distinguishably different than the general term of just prevention. You'll be able to see this through the Institute of Medicine's continuum of care model, where I will show the difference between the different types of prevention. Next, we'll move into the CSAP domains, which should be defined and understood before moving into the selection of strategies. And this would not be a proper foundational knowledge section if it didn't include something about risk and protective factors. So we will revisit those as well. When I do training for prevention specialists, one of the first things I talk about is how we come about doing the work that we do. To do that, we need to first talk about where the funding comes from. Each year, the White House sets a budget for our country, which is passed by Congress. There's a funding that goes to the U.S. Department of Health and Human Services, specifically for behavioral health. From there, the branch of DHHS that handles mental health and substance use is the Substance Abuse and Mental Health Services Administration, or SAMHSA. Within SAMHSA, there are 11 different offices and centers that cover everything from behavioral health equity, financial services, intergovernmental and public affairs, policy, substance abuse treatment and recovery, and finally, substance use prevention. All 11 of these offices and centers are shown on the screen, so you can take a minute to look at those. But for the purposes of this training, we're just going to be reviewing the Center for Substance Abuse Prevention. So what exactly does the Center for Substance Abuse Prevention do? Simply put, their mission is to improve behavioral health through evidence-based prevention approaches. The goal is to develop comprehensive prevention systems by working with federal, state, public, and private organizations. The center provides national leadership in the development of policies, programs, and services to prevent the onset of illegal drug use, prescription drug misuse and abuse, alcohol misuse and abuse, and underage alcohol and tobacco use. The center also promotes effective substance abuse prevention practices that enable states, communities, and other organizations to effectively apply prevention knowledge. These descriptions are very broad and high level in order to apply to all areas of the country, but how they look in communities is depicted in the pictures and short descriptions on the screen. Most of their work is at the federal level and coordinating with state government, so we might not see as much of that in our local community work. And as prevention professionals who work in communities across Montana, we might not usually hear about the CSAP's efforts. For those in the field of substance use prevention, we often just use the word prevention to describe what we do. We are prevention specialists, but on the next couple slides, we're going to dig a little bit deeper into prevention and talk about primary prevention, why it's important to distinguish this from others in related fields who may also use the term prevention. This definition of primary prevention is used by the Institute of Work and Health and applies to prevention in general. It could apply to heart disease, infections, seatbelt usage, or other health behaviors and outcomes. But when we narrow the scope of this definition to fit the parameters of substance use, I'll highlight pieces of this to demonstrate how it applies specifically to substance misuse and abuse prevention. Looking at this definition, it might be hard to identify how it can be broken down into the 6 CSAP strategies, but we'll first start with the words diseases and injury. In this case, the word disease would be a substance use disorder defined by the DSM-5. This definition is patterns of symptoms resulting from the use of a substance that an individual continues to take despite experiencing problems as a result. The word injury in this instance would be injuries that occur as a result of the substance use disorder, such as driving under the influence crashes, or injuries incurred as a result of being under the influence of a substance. Moving further into the definition is where the 6 strategies start to develop. In a later section, we'll discuss this in more detail, but for now, I'll introduce the topics of environmental versus individual strategies. In this definition, exposure to hazards will be those environmental strategies that reach every individual within a defined community, and where it says altering unhealthy or unsafe behaviors and increasing resistance, will focus more on specific individuals or groups of individuals within that defined community. So again, I'll go over how that looks at environmental versus individual, which has to do a lot with the strategies. To further understand the environment versus individual, we'll move to the Institute of Medicine's continuum of care. The IOM model classifies prevention interventions according to their focus population, and classification by population provides clarity to differing objectives of various interventions, which in this case are those 6 strategies. Doing this allows those strategies to match the objectives to the needs of the target population. So that's why this is so important to understand, so we can determine which of those strategies will work best with the population that we're trying to affect. So the IOM identifies the following 3 categories based on their level of risk in a population. We have universal, selective, and indicated. these three categories are also aligned with the environmental versus individual populations. The environmental is a universal population. That's where we find those environmental strategies. And the selective and indicated populations are where we use individual strategies. Moving further to the right, in order to distinguish primary prevention from others in related fields who also use the term prevention, I'll quickly highlight those secondary and tertiary prevention efforts. Secondary prevention happens during the treatment phase of this model. It aims to reduce the impact of a disease or injury that has already occurred. If you remember, primary prevention is before the problem starts. And in secondary prevention, this is done by detecting and treating disease or injury as soon as possible to halt or slow its progress. We encourage personal strategies to prevent re-injury or recurrence and implement programs to return people to their original health and function in the hopes of preventing long-term problems. This differs greatly from primary prevention because in this definition, the disease or injury has already occurred. In primary prevention, we want to keep the disease or injury from ever occurring in the first place. The IOM model classifies prevention strategies or interventions, those terms are used interchangeably, according to their population. Classification by population provides clarity to different objectives of each of the 6 CSAP strategies and matches the objectives to that population. I did mention all of this previously. The 3 levels, again, are categorized based on level of risk. So the first is universal. Universal prevention measures address an entire population, which could be the national population, a local population, a specified community, a school, or neighborhood. It addresses everyone within a designated geographic area. So it shares different messages and programs aimed at preventing or delaying the use of alcohol, tobacco, and other drugs. The mission of universal prevention is to deter the onset of substance abuse by providing every single individual in that defined area with the information and skills necessary to prevent the problem. So the entire population is considered at risk and able to benefit from the prevention programs. The next is selective, and selective prevention measures target subsets of that total population that are considered at risk for substance abuse, but just by being members of a particular segment of that population. Selective prevention targets the entire subgroup regardless of the degree of risk of any individual within that group. Lastly is indicated, and indicated prevention measures are designed to prevent the onset of substance abuse in individuals who do not meet the medical criteria for addiction, but who might be showing early signs, dangerous signs of substance use disorders or addiction. The mission of indicated prevention is to identify individuals who are exhibiting problem behaviors and to involve them in programs that will help reduce those behaviors from becoming worse. Definition sounded fairly clinical. I shared some specific examples of each of these different types of populations. So for the universal populations would be any of those listed on the screen. They are defined populations, both larger and smaller, you can see on that list. They are all considered a universal population because they include the entire population of a specifically defined area. The strategies and activities, however, to be implemented for this population would not be directed at a specific risk group. The information would reach all individuals in the defined group, and everyone would be able to receive the benefits of these efforts. The next group would be selective, and these individuals listed under that title on the screen are all considered at risk for substance abuse by simply belonging to this specific subgroup of the general population. Strategies and activities that are chosen for this population usually benefit the entire subgroup, not any particular individual within that group. So the whole subgroup. Lastly is indicated. For this indicated population, we can see in both examples that the youth involved have already used alcohol, tobacco, or other drugs. They are meeting those early warning signs and showing problem behaviors that could be indicative of a potential substance abuse problem. For primary prevention, this is sometimes where it gets a little bit tricky because we can't cross into the realm of treatment by treating these individuals. We don't have those credentials. That is not within our scope of work for primary prevention. What we do is we can ensure that systems and processes are in place for these individuals to get the services they need, but we cannot do the assessments or treatment of any kind. We'll talk further in section 2 about what these strategies and activities can look like for this indicated population, but for now, know that we are not treatment professionals, we are prevention professionals. Now is where we begin to bring in those risk and protective factors. The CSAP articulates that risk and protective factors and an individual's character interact through 6 life or activity domains, which you can see on the screen. Within each of these domains listed on the screen, there are characteristics and conditions that can function as risk and protective factors. So that means each of these domains presents opportunities for prevention. The 6 domains you can see are environment, community, school, family, peer, and individual. Based on the target population within the universal, selective, or indicated populations, different interventions might be utilized, again, based on who our population is that we're trying to reach. For example, the risk factors associated within the individual domain, you can see on the right, could be addressed by an indicated intervention aimed at increasing the knowledge about or attitudes towards substance use as a means of influencing their behavior. So if we're looking at individual change, again, we could use indicated interventions because we know those indicated interventions are going to reach an individual. Since each of these domains listed have specific risk and protective factors, we'll target those factors and those specific populations through strategies that will affect those populations. Changing the behavior of individuals through these domains listed on the screen is what will change the factors. When you change the factors, that's when it will affect and change the problem behaviors we're targeting. Tying the populations from the 2 previous slides, the universal, selective, and indicated, some of those may be a better fit for these domains. For example, a universal population strategy would work best in environment, community, or school domain. An indicated population might work best in the peer and individual domains. Into those domains, we'll move into more of the risk and protective factors. And like I mentioned, the overall goal in primary prevention is to have the protective factors outweigh the risk factors, just like it shows on the screen. This model is based on the simple premise that to prevent a problem from happening, we need to identify the factors that increase the risk of that problem developing and then find ways to reduce those risks. Just as medical researchers have found risk factors for heart disease, such as diets high in fat, lack of exercise, and smoking, a team of researchers at the University of Washington have defined a set of risk factors for youth problem behaviors. Risk factors are characteristics that are associated with higher likelihood of problem outcomes. They are elements in a person's environment that increase the likelihood of them engaging in health compromising behaviors. These risk factors exist in all domains of social development and are consistent in effects across races and cultures. So it doesn't matter the race, culture, differences, these risk factors are for substance use disorders or health compromising behaviors. Opposite, protective factors are characteristics that are associated with decreasing the likelihood of problem outcomes. They buffer against those risks in otherwise adverse circumstances by reducing the impact of the risk and changing the way a young person might respond to that risk. In our realm of substance use prevention, that's the problem outcome or behavior we're trying to prevent from happening. It's critically important to understand that the factors within the domains, because this is the beginning of how we start to select the appropriate strategies that are a good fit for our community. So we'll get more into that in section 3. Looking specifically at that environmental and community domains, like I said, each of these domains have their own risk and protective factors. So we'll go through what each of those looks like in the different domains. So these risk factors increase the likelihood of a young person becoming involved in substance use. Low neighborhood attachment is related to higher levels of juvenile crime and drug selling, for example. For the second risk factor listed here, research has shown that legal restrictions on alcohol and tobacco use, such as raising the legal drinking age and restricting smoking in public places, that has been followed by a decrease in consumption. National surveys of students have shown that shifts in normative attitudes towards drug use have preceded changes in use. For the last risk factor, simply put, the more substances that are available, the more youth will use. That one's fairly straightforward. On the protective factor side, when opportunities are available in a community for positive participation, youth are less likely to engage in substance use and other problem behaviors because there's more for them to do. Also, not just being involved in those things, but being rewarded by others in the community for their positive participation in activities will help serve as a protective factor as well. Again, lowering their risk for substance use. For school domain risk factors, beginning in the late elementary school, like grades 4 through 6, academic failure increases the risk of both drug use and delinquency. It appears that the experience of failure itself, for whatever reasons, increases the risk of problem behaviors. Factors such as liking school, spending time on homework, and perceiving the coursework as irrelevant are negatively related to drug use. Also, surveys of high school seniors have shown that the use of drugs is significantly lower among students who expect to attend college than among those who do not. Much like in the community domain, when young people are given more opportunities to participate meaningfully in important activities at school, they're recognized and rewarded for that work, they are less likely to engage in drug use and other problem behaviors. So again, in the school domain, much like you saw in the community domain, there's those opportunities for pro-social involvement and again, being rewarded for that pro-social involvement. Moving into the family domain of risk and protective factors, parents' use of inconsistent and or unusually harsh or severe punishment with their children places them at higher risk for substance use and other problem behaviors. Also, parents' failure to provide clear expectations and to monitor their children's behavior makes it more likely that those children will engage in substance use. Additionally, children raised in families that have high levels of conflict, whether or not the child is directly involved in that conflict, appear to be at risk for both delinquency and drug use. The same goes for those children raised in a family with history of problem behaviors. In families where parents use illegal drugs, are heavy users of alcohol, or are tolerant of children's use, children are more likely to become drug abusers during adolescence. That one's kind of self-explanatory. The risk is further increased, however, if parents involve children in their own drug or alcohol using behavior. For example, asking the child to light the parent's cigarette, or this one I have seen personally, asking a child to get the parent a beer from the refrigerator. When those children are involved in that behavior and the parents involve them, the more they see that as parental acceptance of use, even from a very young age. On the opposite side, for those protective factors, young people who feel that they're a valued part of their family are less likely to engage in substance use and other problem behaviors. They have that family attachment. Those last two factors, again, are very familiar that you saw on that school domain and the environmental community domain. Opportunities for pro-social involvement within their families. So when youth are exposed to, involved in, and rewarded and praised for their meaningful involvement in those positive family activities, again, protects them, reduces the likelihood of engaging in those problem behaviors. You can see there's a lot of both risk and protective factors for the peer and individual domains, so hang in there with me as we go through all of these. Young people who don't feel like they're a part of society, they're not bound by any rules, they don't believe in trying to be successful, they don't want to be responsible. They also might have a high tolerance for deviance or who take an active rebellious stance towards society. All of those are contributing factors and make them at higher risk of abusing drugs. Additionally, when they're rewarded for this antisocial behavior, they're seeing positive results from acting out or choosing deviance. This, again, exacerbates that, and they are at higher risk for engaging further in this negative behavior, which does include substance use. And this next piece is especially important. Could be the largest predictor of future use is early onset of drug use. The earlier the onset of any drug use, the greater the involvement in other drug use and the greater frequency of use. Onset of drug use prior to the age of 15 is a consistent predictor of drug abuse later in life, and a later age of onset of drug use has been shown to predict lower drug involvement and greater probability of discontinuation of use at a later age. Along these same lines, during the elementary school years, most children express anti-drug, anti-crime, they're pro-social attitudes. They have difficulty imagining why people would use drugs or engage in that behavior at that young age. However, once they reach middle school, as more youth are exposed to others who use drugs and engage in this antisocial behavior, their attitudes might shift a little bit towards more acceptance of these behaviors. Youth who express positive attitudes towards this drug use or this antisocial behavior and who might associate with those peers who are engaging in that behavior, they are more likely to engage in many of those problem behaviors, including drug use. Peer drug use has consistently been found to be among the strongest predictors of substance use among youth. Even when the young people come from well-managed families, low family conflict, clear boundaries and expectations, and they might not experience other risk factors, spending time with friends who do use drugs greatly increases the risk of that problem developing. Lastly, depressive symptoms have come to the forefront as mental health has been discussed more and more in recent years, especially with aligning with substance use. So young people who are depressed are overrepresented in the criminal justice system and are more likely to use drugs. Survey research and other studies have shown a link between depression and other youth problem behaviors. Unfortunately, to combat all of these risk factors, and you can see visually on the screen, there are more risk factors than there are protective factors. Some of them for the protective factors are religiosity and belief in the moral order. Young people who regularly attend religious services are less likely to engage in problem behaviors. They have a strong belief of what is right and what is wrong, are therefore less likely to use drugs because they see drug use as wrong. And much like the other domains previously visited, participation in positive school and community activities helps protect the youth from that antisocial behavior and substance use, as does associating with peers who do the same. So a lot of it for this younger peer and individual age group depends on who they're hanging out with. So as we wrap up section 1, I want to reiterate that the CSAP strategies are not just strategies chosen at random because prevention professionals might feel like that would be a good fit for their community. While that is a piece of it, There's a great deal of theory and research behind the strategies that shows their effectiveness at reducing substance use. So we looked at risk and protective factor theory in the previous slides. We also looked at the social development strategy a little bit when we talked about which risk and protective factors belong in which of the domains. And it's important to learn about the population types for those risk and protective factors because it helps us choose which strategies to use depending on which populations we're trying to reach. Are we trying to reach the families? Are we trying to reach the youth in the peer and individual school age domain? Depending on the domain, will determine which strategies and activities we choose. So as we move into the next two sections, but especially section 3, we will revisit these theories a little bit and how to apply them to those CSAP strategies and activities that we are going to learn in the next section. Here is a knowledge check with several questions. Question 1, true or false? The mission for the Center for Substance Use Prevention is to improve behavioral health through evidence-based approaches. True or false? The goal of primary prevention is to prevent diseases or injury after they occur. The following is a definition of which target population from the IOM continuum of care. It targets those already using or engaged in other high-risk behaviors to prevent heavy or chronic use. Is it A, universal, B, selective, or C, indicated? The following is a definition of which target population from the IOM continuum of care. It targets the general population and are not directed as a specific risk group. Is it A, universal, B, selective, or C, indicated? Definition of which target population from the IOM continuum of care. Targets those at higher than average risk for substance abuse. Is it A, universal, B, selective, or C, indicated? Lastly, fill in the blanks. The 6 domains used for CSAP strategies are Now that we're moving into section 2, this is where we start to build our knowledge of the 6 strategies. As we move through each of the strategies, you'll start to see how the definitions we reviewed in section 1 start to apply and how the strategies can be used within those domains to affect change. So the first thing we'll do is define the 6 strategies, which show how they differ from one another. We'll be reviewing which strategies constitute direct and indirect, which will help later down the line when we're looking at making environmental or individual level changes, which does relate back to that continuum of care we reviewed in section 1. And last, we'll explore the activities that are included in each of those 6 strategies, define the activities, and then share some examples. Up until this point, we've gone over prevention theory, but now we're going to get into what most people really want to know more about. What are the strategies? What does each of them entail, and what do the definitions mean? I'm going to go into much more detail on each of these in a few slides when I get to them, but for now, I'll just give a short intro to each of them. Information dissemination, or sometimes called dissemination of information, that's the same thing, is when the prevention professional shares information to the community. There's a lot of different methods how that can be accomplished, but simply put, it's the sharing of prevention information. Prevention education is the use of an evidence-based program or curriculum in a defined setting. This is sometimes confused with information dissemination, especially when it comes to giving community presentations about prevention. And what differentiates these two from one another is that prevention education follows a specific curriculum that is evidence-based, where information dissemination does not follow a studied or evaluated curriculum. Big difference. The best way to explain this difference between the two is that information dissemination is what we want people to know. Prevention education is what we want people to do. That's important. You should write that down. Alternative activities are simple, very straightforward. They are positive activities that keep the focus population away from negative behaviors. Very simple. Community-based process can be a very broad topic, but the bottom line is that this strategy is helping to gather and mobilize communities to create positive change. Environmental approach is where policies and practices that are proven to be effective in reducing underage substance use and other problem behaviors are developed and enforced. So there's two pieces to that, developed and enforced. And again, we'll get to that later, what each of those means. These can be on a smaller scale that includes like a workplace policy, a school policy, or on a larger scale that can include something anywhere from like city ordinances, city laws, up to state laws. Problem identification and referral, or PIR, looks at improving systems within the community that provide support and help to individuals who have been identified as possibly needing assistance with their problem behaviors. That sounds a lot like that indicated population we've talked about. So each of these strategies are intended to reach specific population, and this population falls into the categories we talked about in section 1, universal, selective, or indicated populations. And depending on which of those is chosen, could determine which of the strategies are then employed to carry out the activities. Knowing that helps us transition into the two categories that strategies can fall under, which are direct and indirect. So we have these direct or indirect strategies, and which of those are chosen is based upon the population being focused on by the prevention professional. If someone's looking for individual level change, they would choose direct strategies and activities. And if they're looking for community change, which is often called environmental change, they would choose indirect strategies. It would be the difference between what behavior do I want to change in this individual or group of people versus what behavior do I want to change in the entire population. Besides that, there is a major difference between the two. Beyond looking at individual versus community level change, the key item that separates these two from one another is whether they have one-way or two-way communication with the intended audience. When we're looking at this individual level change, these are going to be the direct strategies. So the community change will be more of that environmental and indirect strategies. Each of the strategies I mentioned a few slides ago, all 6 of them, are considered direct or indirect with a few exceptions. If a prevention professional is looking for individual level change, they will choose those direct strategies and activities. And if they're looking for community level change, which again is the environmental, they would choose the indirect strategies. We know which is direct, which is indirect. Here's a list of how each of the 6 activities aligns with being direct or indirect. For the most part, the strategies will align this way. The only exception is with some of the information dissemination activities, which I'll get into more of when we go over that strategy specifically. But you can see how it has arrows that go both indirect and direct. So direct activities include prevention education, alternative activities, and problem ID and referral. If we think back to the previous slide that included the definitions, all of these strategies have direct contact between the prevention professional and the intended audience. So it has that two-way communication. When you have a prevention education curriculum, the curriculum will be taught to a specific group of people who are identified on the logic model or whatever prevention plan you're working with. Same with the alternative activities. If you plan an activity such as an after prom party, the intended audience would be youth attending prom. That is the direct group of youth whose behavior you are trying to change. Indirect activities include information dissemination, community-based process, and environmental approach. When a preventionist is working on these strategies, they're often working with other professionals to change systems, collaborate, share information, trying to change the environment. When you work with a coalition to enhance community processes, the individuals you're working with on the coalition are not the individuals whose behavior you're trying to change. When you're working with city council to enhance a city ordinance, you're not trying to change their behavior. Together, you are all working to change the entire community's behavior. You might be sharing resources, enhancing each other's efforts, making changes that will affect the entire population of an area. So you are working indirectly with the intended audience by working with others who are also working on the same goals. Looking ahead to section 3, we will look at how these can work together to create the biggest impact with direct and indirect. Now that we've looked at the 6 strategies and whether they are direct or indirect, let's go over each of them and some of the overarching broad categories that have more specific activities within each of them. First is information dissemination, and just a side note, these don't go in any specific order. This is just the order I have them, so the order is not of any significance. So information dissemination is a strategy that provides awareness and knowledge of the nature and extent of alcohol, tobacco, and drug use, abuse and addiction, and their effects on individuals, families, and communities. It also provides knowledge and awareness of available prevention programs and services. Information dissemination is characterized as either direct or indirect, depending on the activity. Most of the time, the activities have one-way communication, like I had mentioned earlier, but there are a few when it will be possible to have two-way communication with the intended audience, and we will go over specifically what each of those are. Information dissemination prevents a very wide variety of options and can be used in communities of all sizes and stages of readiness, which is why it's used a lot and should be used a lot. When the definition mentions awareness and knowledge, we have to remember that while prevention professionals look at the data and substance use information every day, we're very familiar with it, most people in the community don't operate in this realm, and they may not even realize that these are issues in their community. So what information dissemination allows is us to share that information no matter how much knowledge an individual, organization, or community does or does not have. So the first part of the definition speaks to that. The second part talks about letting the community know what types of programs and services are available that can help mitigate or prevent problem behaviors. Some of these might be specific prevention programs, but some of them may be other organizations or services within a community that are meant to build up those protective factors. Next, I'm going to draw your attention to the indirect and direct boxes. On the previous direct and indirect slide, I shared that there were a few exceptions to that, and this is one of them. When we are using information dissemination, one-way communication can include newspaper articles, radio, public service announcements, or brochures placed at a doctor's office, for example. This means that prevention specialists send out the information, but the audience who sees it or hears it does not have the opportunity to talk to the prevention specialist about it. On the flip side, some information dissemination activities are direct, where the intended audience does have the opportunity to talk to the prevention professional who is distributing the information. An example of this might be a Red Ribbon Week presentation in a classroom or hosting a booth at a health fair. The audience can interact with the person presenting the information, they can ask questions, and have dialogue about the information presented, which is really great. So I will go into each of these indirect and direct activities next, and you'll get to see what they look like a little bit more. I will say, though, this strategy and the activities contained in it will take more time than most of the other strategies due to how many activities there are and unique nature of them. So I've broken them up into groups, and some might take a little bit longer than others to review. That's just a forewarning for you. This is a large list of activities that are considered indirect or that one-way communication. That means the prevention professional can conduct these activities and share their information. But once it reaches the intended audience, that audience is not able to communicate back directly with the prevention professional. So I've kind of broken them down into 3 groups that somewhat relate to one another, and I'll go into each of them in a little bit more detail in the next couple slides. This last list of indirect information dissemination activities it covers a lot, and these activities tend to be a lot larger in scope than some of the previous activities I mentioned. So I will go over them in more individual detail, and they usually involve a lot more planning. They include all types of media in their efforts, including many of those listed on the previous media slides. So where I had mentioned the radio or TV PSAs or ads, or you can kind of do them as a one-off, or the newspaper stories, you can do one or maybe a short series, but those are usually included in a lot of these media campaigns, a sticker shock campaign or social norms media campaign. So this will be a more comprehensive look at what these activities entail. On that list, media advocacy is used mostly for health promotion as it relates to public policy initiatives. Media advocacy is the strategic use of mass media and community advocacy to change the social environment or advance a public policy initiative. The goal is to use the media to change the social environment in which individuals make personal behavior decisions rather than provide instructive health information to motivate people to make individual decisions. So the major difference between this and a media campaign is that it shifts the focus from education to change an individual's behavior to the larger environment and how a policy can help make that environmental more healthy or positive. So there's many great tools available to look for media advocacy help, but I compiled a few to start the process. They are the Public Health Media Advocacy Action Guide. The Community Prevention Institute has a media advocacy guide, and the Office of Juvenile Justice and Delinquency Prevention also has a media advocacy guide. And those will all be shared apart from this webinar. So one great example of a media advocacy campaign is from the American Lung Association, when they advocated for the minimum tobacco age of purchase to increase from age 18 to 21 at the federal level. Those advocacy efforts helped, and that law was signed into federal law in December of 2019. State and local advocacy efforts have also taken place in a lot of Montana cities and towns in the form of marijuana city or county ordinances, when the adult use cannabis became legal to use in Montana several years ago. Shifting from that last activity of media advocacy, we move to a media campaign. In the previous slide, we talked about how media advocacy can help us get community support to change local ordinances around marijuana dispensaries. If we were to do a concurrent media campaign about marijuana, it could focus on healthy youth behavior with marijuana use prevention messages. So while both focus on marijuana use prevention, advocacy would focus on implementing ordinances, while the campaign focuses more on an individual behavior. So that's the difference between the advocacy and the media campaign. It's environmental versus individual. As a whole, media campaigns are a very well-planned and thought-out series of print and broadcast media that deliver health promotion activities, prevention information, stuff like that. In our realm of substance use prevention, our topics would be related to those topics. If we're looking at a complete and comprehensive media campaign, we would look at including all activities such as public service announcements, newspaper articles, flyers, brochures, billboards, social media, presentations to community groups, TV ads, giveaways with the media message on them, posters, the list could go on forever. So in a well-planned media campaign, there would be a schedule and calendar of when and where all these activities and items would be implemented and distributed to achieve the greatest impact on our focus audience. So this planning ensures that all modes of distribution are considered so the highest possible amount of people can be reached with this message. The other goal of it being planned and comprehensive is so the audience receives the same message in different mediums and locations over different time periods. When people continue to see the same message over and over, it's more likely to be ingrained in their mind. They're going to remember it better. So that's why we do that. One thing I'd like to point out in each of the images that are used in Oregon's Stay True to You campaign is that all of them are focused on healthy activities. So if you look up on the screen on the left-hand side, all of those pictures. They are a healthy parental figure, skateboarding, playing the guitar, employment, reading. This is very important. No scare tactics are used. There are many media campaign resources out there, but one of the most important that I've found in my work as a prevention professional is from the Frameworks Institute. They are an agency who applies social science methods to study how people understand social issues and how to best frame them using high standards of theory and practice. And they don't use scare tactics. They're helpful tools, the Frameworks Institute. They have one called Reframing Adolescent Substance Use and Its Prevention, a Communications Playbook. I have used that a lot. And again, if you just Google that, Reframing Adolescent Substance Use and Its Prevention, a Communications Playbook from the Frameworks Institute. It's very helpful. Another resource used heavily in Montana is parentingmontana.org, which is a media campaign specifically designed for parents and those in a parenting role in Montana. It was developed through a partnership between Montana State University's Center for Health and Safety Culture and Montana DPHHS. It was created using the positive culture framework, and more of that can be found on that parentingmontana.org website. Last slide, I mentioned the positive culture framework, but now I'll go into it a little bit more detail to explain how we use that concept to apply to social norms media campaigns. So the National Social Norms Media Center at Michigan State University says the social norms approach focuses on positive messages about healthy behaviors and attitudes that are common to most people of a specific group. In the context of substance use prevention, these campaigns correct the misconception about peers' substance use and focus on the reality that most youth do not use alcohol or drugs. It frames the messages in a way that shows the majority of your peers are engaging in positive choices and healthy behaviors. And by doing this, it kind of shifts that adolescents' thoughts of feeling left out and thinking they're the only ones not using into knowing that's not true. That's not the case. They belong to the majority of their peers who do not use. As I mentioned in section 1, youth perception of their peers' attitudes and behaviors have the largest influence on their own attitudes and behaviors. Unfortunately, their perceptions are often inaccurate, and they tend to overestimate the number of their peers who value and make unhealthy choices and underestimate the number who value and make healthy choices. So that would be a case where this might be an effective activity. So to effectively use a social norms campaign, make sure that the norms that are being highlighted reflect a group that the youth can closely identify with. If they can't see themselves in the campaign and making similar choices, the message will fall flat. Another thing to avoid is messages of morality from authority figures, because youth don't identify with those individuals. And I said it on the last slide again, scare tactics should not be used in any media. They are ineffective, proven ineffective at making any sort of behavior change. Looking at the example that's on the screen, it's a super cute example. The first thing I want to point out is that it was created by members of a youth coalition. They know what messages would reach and resonate with their peers, and they came up with a catchy message and picture that was sure to capture attention. At least that's what they thought their peers would enjoy seeing and would actually capture their attention. So there's no scare tactics. The message shows the norm that already exists in their peer group and highlights how most of the students are making these healthy choices. So this is a great example of a social norms media campaign. The message behind it, at least. So our last example of the indirect information dissemination activity is the sticker shock campaign. This activity is less of an overall media campaign, but instead focuses on a very specific niche and target audience, which be adults 21 and over. This specific campaign is where youth, alcohol retailers, and members of the community come together to reduce youth access to alcohol by printing messages and placing them where alcohol is sold. The message usually requests that anyone 21 and older does not buy alcohol for anyone under 21 and will often list the legal consequences if they were to do so. So these messages are in printed form and they usually come on stickers, window clings, posters, flyers, coasters, other things. The stickers can be placed on cases of beer or other alcohol if that's allowed. And window clings can be placed on cooler doors. Always make sure you get permission from the convenience store or grocery store, wherever you are wanting to place these items. Obviously, get their permission before you do that. Posters or flyers are often placed near the point of sale or even on the doors entering an alcohol retail establishment, so those entering can see that message as soon as they arrive. I've seen these sticker shock campaigns, they can get pretty creative and the way that they're carried out. And I've actually participated in several of these myself and used focus groups to help design the message of the stickers that were used. So the group I was working with at the time worked with retailers to place stickers on the products, window clings on the coolers, and these things called shelf talkers that hung off of the shelves where the non-refrigerated alcohol was held. And that example you can see in the picture on the right, that's called a shelf talker. And we also had bag inserts that went into grocery store sacks for those purchasing alcohol. And yeah, I think that was about it. So we did more than that though. That was just placed around the product in the stores. We did actually decide to write several press releases about it, explaining what we were doing and that people might see the stickers in the store and on the products, so they knew what it was when they saw it. And in the article, we also shared local data that the number one place youth in our county at the time, the number one place they obtained their alcohol was from people over the age of 21. So this campaign directly affects the source of alcohol that youth were getting it from. So overall, I would say the whole campaign was fairly easy to implement, and there was a lot of buy-in from the grocery and convenience stores, more than I thought there would be. And they felt like they were doing something to make a difference. And the one last thing that I'll point out about this is that this message and these stickers were designed by a focus group of individuals over 21. So the people who were the same age as those that we were trying to target, people over 21, they came up with this message, and they came up with the colors, the fonts. We used a focus group to create this sticker and this message, and this is the one that they said would get their attention the most and that they would pay attention to the most. So that was another instance where we used our focus population, a focus group of them, to create this sticker to make the best impact. Moving on to the direct information dissemination activities, remember that these are when the preventionists can have two-way communication with their focus population. If your audience at a health fair presentation or town hall meeting wanted to ask a question back to you, they could. The two that I'll highlight are health fairs and, on the next slide, speaking engagements. Both of these activities have the goal of increasing knowledge of substance use, but they differ slightly in their delivery. At health fairs, you have a very short amount of time to capture someone's attention and share your message. Health fairs are intended for the general population, where you could have everyone from school-age children to senior citizens, all ages. Both booths usually aim to have information for all ages or maybe a certain group of people, depending on where you're hosting the health fair. And one thing, it's very helpful to have an interactive component to get the people that are walking by sort of drawn into your group. So when you do that, you can take a moment to visit with them, ask them questions, share the information that you have, and just have a chance to chat with them. I have been to many health fairs in my career and had some that were very, very well attended. They had hundreds of people of all ages, and I've had others where maybe only a couple dozen showed up. The best interactions I had with my booth were those that involved a game of some sort and always a giveaway. People come specifically to the booth and ask, what are you giving away? So it draws them in, but while they're there, then you can share the message. People love registering for those giveaways. I will expand on this a little bit though and say that hosting an information booth at a health fair is only a piece of what you need to be doing. And you can get very creative when looking at community events where you can host a booth. So the health fair is just the start of it. Others I've seen or heard where tables were very well attended or the reception was very good were at like basketball tournaments where there's hundreds of people, back to school nights, parent-teacher conferences, kindergarten screenings and registration, mental health or suicide prevention walks, maybe a direct seller showcase. And so there's so many others. Just think of community events and on maybe your community calendar if you have one and see what's happening. Contact the organizations or organizers of that event to see if you can host a booth or if it would be appropriate to host one there. The worst thing they can do is say no, but it could potentially open up a whole new audience to reach. And now I'm going to talk about creating and designing your booth. I want you to think about a couple of things. I mentioned the interactive component, but also think about what information do people want to see at your booth. What you might think would be super informational, great for them to know, maybe they don't want to see that, but you know that it needs to be interactive. It needs to do something that creates their buy-in. You want to share this information. They need to know this information. So you need to make it kind of inviting, interactive, so that they will come and you can share that message. So I would also say try to focus on one thing. Do you want to focus just on underage drinking? Do you want to focus on suicide prevention? Or do you want it to be more of a coalition building tool where you talk about what your coalition does, try to get more support for that? There's a wide variety of things that you can do. But again, most people like giveaways or handouts from those booths. They could be like pencils, stickers, stuff like that. Make sure it's useful. Be very thoughtful when you're purchasing these items. And make sure it's something that people are actually going to use and not just throw away when they get home. So speaking engagements are the next thing that I will go over, and you'll see how that is different from a health fair. So how are these speaking engagements different from a health fair or hosting a booth at an event? And the number one thing, they have more longer interaction with your audience. It's usually a captive audience, whereas the health fair, it's just quick people passing by, might have a couple people stop and have longer conversations with them. But with the speaking engagement, they are captive audience with you there for a longer amount of time. These can be done in a variety of venues where you can share your message in more detail. They can be more dialed down in terms of topics than a health fair booth might be, and are usually done for a specific purpose. So there are so many examples of presentations that can be given, but one that comes to mind is when schools contact prevention professionals and ask them to do a presentation to students on a specific topic like vaping or maybe during Red Ribbon Week. They rely on you as the prevention professional to be the expert on this topic. So it's our job to be the best we can and bring information to our intended audience. And in presentations like these, the goal is to increase the knowledge of the audience and maybe start to change behavior. Another example I hear often is when coalitions give presentations to other community groups on who they are and what their goals are. Presentations like these usually include an ask at the end where the coalition is asking for some sort of support. And I would really encourage that because that's going to keep the conversation going. That's going to make people want to do something. So if you're giving a community presentation, I would definitely include an ask at the end. What is it that you want them to do next? When doing your presentations and planning for them, I encourage everyone to put a lot of thought and research into their presentations. There are some best practices that should be followed. Some are the same as I mentioned previously, like not using scare tactics or that myths versus facts. Don't do those. One thing is if you're sharing data, visit the Evergreen Data Intentional Reporting and Data Visualizations website to learn how you can be most effective in delivering data in a variety of formats. There's lots of different ways to do that. Some work better than others. There's also a lot of PowerPoint best practices that should be followed, and they can be found through some simple research on the web. And we also Youth Connections did a regional training recently that had a focus on giving presentations, and we have that information on our website. So bringing this strategy to a close, I think it's important to reiterate that this strategy provides awareness and knowledge of the nature and extent of alcohol, tobacco, and drug use and their effects they can have on individuals, families, and communities. It also provides knowledge and awareness of available prevention programs and services, also very important. So using these activities effectively, all these activities that I reviewed, the goal is to increase people and the community's knowledge of the problem, which will lead to a change in behavior. They should include messages of positive behavior, what we want people to do, and not necessarily focusing on what we don't want them to do. If we know better, we do better. And while it's easy to say that, it may not be possible to do that without also increasing our skills and abilities. That's where our next strategy, prevention education, comes into play. So prevention education is the second strategy we'll go through, and you'll see how important it is as it includes evidence-based programs that reach a direct population. It often gets confused with information dissemination, as I kind of explained previously, but the difference is that these activities use programs that follow a manual. They've been evaluated for their effectiveness, where information dissemination activities do not. We will talk more about what evidence-based means and the different types a little bit further into this section. So this strategy's activities are considered direct, and if you remember from section 1, direct activities are those that provide two-way communication between the facilitator and the audience. In this case, the facilitator is usually an individual like a teacher, counselor, other professional who has been trained in that evidence-based program and are qualified to teach and implement the program. Adding on to that, because it's a direct activity, if there is a specific group of at-risk individuals that need to be reached, we can also use this strategy to work with selective and indicated populations, if you remember back to section 1. One other thing you'll notice in this strategy is that I don't go into as much detail on these activities as I did for information dissemination. They're mostly the same activity, but just focus on a different population. On this list is working with a selective population. young adults or children of individuals who use substances. These are educational programs or services such as a risk and protective factor education program or something like adult children of alcoholics meetings. Those are kind of along the same lines as Al-Anon meetings, which are a mutual support group for people whose lives have been affected by someone else's drinking. Classroom or small group sessions are what we most often think of when it comes to prevention education. These would be lessons, seminars, or workshops for youth, adults that are mostly done in a classroom type setting. And these could cover a variety of programs for all ages, all the way from preschool up to college students. And like I said, these are all usually session-based. That's one characteristic that most of them have in common. Different examples of these might be the PACS Good Behavior game or like a life skills curriculum taught in high school. The next, educational services for adult groups or youth groups, are very similar to those classroom or small group discussions, but the biggest difference is that these are conducted at places like Boys and Girls Clubs or maybe Girl or Boy Scouts. So it's not necessarily a school classroom, but you're still working with a captive group of youth that belong to a youth organization. Very similar, but slightly different. The next is parenting or family management services are another way that we hear about the parenting classes. There's a lot of evidence-based programs out there for parenting, and that they can be done in as few as 2 classes, some up to 15 weeks. It just depends on the program and what the needs of the community are. And that's how you choose the program that you're going to use. Most of them are broken down by ages or groups of ages. Some examples of these might be active parenting, and with that one, they have different courses for parents of different age groups. They have like a preschool age one up to 4 years old. They have a young child one that might be like 5 to 9. They'll have a teen one, so different programs for different age groups of children. Other parenting classes are like creating lasting family connections, or Family Matters is another one. Love and Logic's another one. There's several out there. The next is peer leader or peer helper programs. And these are not usually a session-based curriculum, but they do use an ongoing prevention activity. These happen between peers. So think people of the same age, ability, or social standing, where one peer provides support and guidance and other risk-reducing activities to another peer. An example of this one might be a peer tutoring program, peer support activities, like a youth group would be an example, or maybe a youth leadership institute, something like that. Cultural programs are listed last on here, but I'm going to go over those into more detail on the next slide. To sum this up, these are usually mostly formal, structured activities that follow a curriculum with a manual. Montana has the evidence-based work group that reviews programs to see if they would be a good fit in Montana. If they are, they're placed on a specific list that's available online, and I will get more into that in section 3. Is a saying that's used a lot in the prevention world when talking about different cultures, and that is culture is prevention. In Montana, DPHHS has created a substance use prevention guide for cultural programs, and it's so important to include these because there are pieces of these programs that enforce cultural values, traditions, and norms, things that are important to those cultures. And in addition to that, there are certain evidence-based programs that we have that are classroom or small group sessions that are the American Indian Life Skills or the Indigenous PACS Good Behavior game. So a lot of these are on that evidence-based work group resource list that I mentioned, but there are some in this guide that was created. And I do have the link to the resource along with the resources for this webinar. prevention education, and the next CSAP activity we will look into is alternative activities. So first, I'm going to share a little story to aid in the discussion of this strategy. Throughout my experience as a prevention specialist, I often had people ask me, "So what is it that you do?" And it was a really hard question to answer because prevention is a very intricate science that's hard to explain in layman's terms to the general person who's not familiar with it. Prevention success and change is usually hard to visualize, and it's hard to see in the community and hard for people to relate to because they've more than likely never heard of it. I found the best way to answer this question was to give examples, and most of the time I ended up using alternative activity examples. Alcohol and drug-free post-prom or graduation parties, a kids carnival, a community cleanup with youth volunteers. Those are all things that people can visualize and provide an anchor to a piece of what prevention is. I would then build upon that, and I found that that was usually a good starting point. So alternative activities provide opportunities for positive behavior support as a means of reducing risk-taking behavior and reinforcing protective factors. And usually, these are most ideal when they are tied to a specific risk or protective factor. So that story, people could see like post-prom party or graduation party, it's tied to that risk factor. They know that sometimes it might be a norm that kids drink on graduation night. So that alternative activity, a drug and alcohol-free graduation party for graduating seniors, that's tied to that specific risky event that sometimes things can happen. So that's kind of the tie-in for alternative activities and using those examples for people to see, yeah, okay, that's the work that prevention does. The whole premise of alternative activities is that when people, whether younger or older, are involved in positive, healthy activities, they are not involved in negative activities. Fairly straightforward. In our case, we are specifically focused on alcohol or drugs, just like the post-prom parties do. Now, in the definition above, the second paragraph mentions offset the attraction to or otherwise meet the needs, which is important to point out here. If I were to be teaching this topic in a room full of prevention specialists and ask the question, how many of you have heard a community member or stakeholder say, "Kids drink because there's nothing to do"? I bet that close to 100% of them would raise their hands. People often think that the only reason kids are using alcohol or drugs is because they're bored, and the natural and easy solution is to create opportunities for them to be involved in positive things. While there's a piece of that that's true, it's important to realize that this is only one of the strategies for prevention, and prevention science tells us we will be more effective with positive change if we can use all 6 of the strategies. We can give them something positive, but if we don't also increase their knowledge and skills to resist peer pressure, these activities alone are not going to be effective. Obviously, since it's one of the strategies, there is a place for that. So we'll learn about what sort of activities fall under this strategy. And often with alternatives, you might find that this is where the community goes to first. Let's create fun activities. And yes, it's fun and it gets people involved. We need to remember, again, this is only one of the 6 strategies. So again, as I mentioned earlier, these different strategies, alternative activities, prevention education, they don't have as many activities under them as information dissemination was. So I really only have this one slide to share with the specific activities for alternatives. When I shared my story, I mentioned that post-prom and post-graduation parties, and those would be an example of the drug-free social and recreational activities that you see on that first bullet point. These type of events are exactly those that the alternative activities definition mentioned, where the focus population we're trying to reach is involved in a drug and alcohol-free activity. The goal of these types of activities is to provide them specifically during times when there's a higher potential of youth substance use, and the hope is that youth will have less time to participate in the alcohol, tobacco, or other drug use because they're too busy and they would rather participate in the positive activities instead of that harmful behavior. So these can take place mostly anywhere in the community, and sometimes it might depend on the event. But these are very popular, and this is a very broad activity that a lot of things could fall under this. Building onto that, as you see below that, are community drop-in centers and drug-free dances and events. Drop-in centers are mostly just one location where the sort of activities take place, and the staff are employed to plan and host the activities. For community service activities, this is along the same lines as the social and recreational activities, but this activity is specifically focused on serving the community through positive activities such as a community trash cleanup event, or maybe an event to repair or rebuild part of a neighborhood park, something like that. The last two on the list, mentoring programs and youth and adult leadership activities, are very similar as well. Mentoring programs are defined as a relationship over a prolonged period of time between two or more people in which the older, more experienced individual provides stable support and guidance to help the younger, could be at-risk youth. Youth and adult leadership activities are different from mentoring activities in that they just are often one-off events and not those that take place over a longer period of time. For those mentoring programs, they can be formal, informal, and they can take place in a variety of settings. They might take place at a school or a community organization, something like that, like Big Brothers Big Sisters. That would be an example of a mentoring program. Our fourth CSAP strategy is community-based process. This focuses on capacity building, which includes ongoing networking activities, collaborative systems planning, technical assistance and training for different community groups and agencies, and assessing community readiness for their preparedness to engage in prevention services. Prevention efforts will only be sustainable if they are truly community-driven. And when a prevention specialist start working in a community, this is often the place that they start. They have to build relationships and trust within the community, and it all starts with getting to know people. In order to create that community change, the community has to be ready and prepared to make that change. And again, it all starts with relationships. The definition on the screen sounds like a lot of fancy words, but it's really all about that relationship building and utilizing others in your community to create change. In this strategy, the objective is to develop the skills of the community stakeholders, who will then in turn do the same for other members or groups of people. And this acts as a ripple effect. We are sharing our prevention knowledge and skills with others, which will help enhance the whole community and the community's effort for effective prevention. When we're thinking of who these stakeholders are, we're trying to think of who might be the most impactful. Looking at this list, they each have a specific role to play, but not all of them are needed to create effective change. It's better to do a few activities well than to give just half of an effort to all the activities. So the first one, looking at accessing services and funding, this is mostly related to the funding piece of that. For this activity, a prevention specialist would assist in possibly researching available funds that could be accessed by their community. And this mostly focuses on their ability to conduct prevention, so prevention-related funding sources. Or they might help coordinate state or federal grants. They could compile a list of financial resources a community could apply for in the future if they chose to do so, and they might even help develop program budgets. The next activity, coalition building, is one of the most important things in prevention work. When a community has a coalition, the coalition is used as a driving force of change, not just the prevention specialist. Some communities already have a high-functioning coalition that have been in existence for a couple decades. In cases like this, the prevention specialist would come in alongside the coalition's current partners and work with them and provide them with technical assistance if they need it. In this case, a prevention professional would provide guidance to the coalition or its member programs that could help strengthen or enhance their activities. And the whole goal of that is to promote prevention in those activities. One important note I'll share is that this assistance should usually result in a product, such as a logic model that has an action plan. Might be an evaluation, organizational or resource development, could be the addition of programs that are offered from that partner organization. Looking at that coalition building, if there's no current coalition, the prevention professional would work first to engage potential community partners to educate them on prevention and their goals within the community. They would continue that until there was a group of partners that kept forward momentum, and they could all eventually reach out to others to get them involved. So again, there's that ripple effect. That's the simplest explanation and hope that it works like that, but the reality is it does not happen that way most of the time. I could spend so much training on coalition building, but there's a lot of resources on that are helpful, like cadca.org, and that can do a much better job teaching you than I could for that. In many small communities, they may not have a true functioning coalition that focuses just on substance use prevention. A functioning coalition might look different. I know my experience in Eastern Montana, there were very, very few coalitions that just focused on youth prevention, but we had DUI task forces. We had a couple local advisory council for behavioral health. We had several different options for us to get involved. So that's something to keep in mind. If you don't have a coalition, you might look to join a group that's already in existence. The next activity, community and volunteer training, is not very prevalent and used at the current time in Montana. And some of that is because it appears very similar to technical assistance for coalition members. So in this activity, these structured training events would teach organizational development skills, usually to an individual or a community group. The best example I could share for this would be if a community wanted to implement Neighborhood Watch, the prevention professional would help organize the training for those interested. Next is community mobilization. This is very similar and often aligned with coalition building, but it can be more broad than that. In this activity, the community is truly the driving force behind the change, as it should be. And they are the ones that are conducting health assessments, developing health improvement plans, carrying out the plans, and using the coalition to help with all of that it entails. When a prevention professional chooses to work on community mobilization, they are doing more than just coalition building. They are trying to reach all areas of the community to get sustained participation to hopefully truly enhance and sustain the overall health of the community. The last one, systematic planning, can also be a part of this process. Since this is an activity where structured services and communities assess and identify current prevention resources and needs, then that systematic allocation of prevention resources can be done on an as-need basis, and how this looks is usually in the form of an organizational or strategic plan. Activity definitions on the previous slide, they can sound very familiar, and it might be confusing when you're trying to choose which of those to utilize on your community action plan. Which one is going to work best? One thing I want you to remember is that these 6 strategies are used in all communities doing prevention all over the United States. In our frontier and rural communities, doing many of these, sometimes it's not possible because there just isn't that many resources to find or review. In comparison, a prevention professional working in Houston, Texas, might be able to just work on accessing services and funding for months and months because there's so many options available in their community. Someone in Montana, it might not take them very long. So to be effective in Montana, we should focus on 1 to 2 of these activities in this strategy and doing them very thoroughly. If there is no current community coalition, I would recommend looking at either community mobilization or coalition building to focus on. The reason I say community mobilization is that it actively involves helping conduct a community health needs assessment and health improvement plan, and those are some of the most important things that you need to start with when you're trying to work on problems in your community. Most, if not all, counties in the state have one, and as we know, the first step of the strategic prevention framework is assessment. We can't know what problems to solve if we don't have the data to show us what the problem is. Lastly, for this strategy, when choosing, remember that this is a community action plan and the activity should reflect the community's decision, not just the prevention specialists. So what is it that the community wants to focus on? The fifth CSAP strategy is called the environmental approach. When we're talking about that, we're looking at the environment and how it impacts a person's behavior. If their behavior is not what we'd like it to be, for example, underage alcohol use, what can we do in the environment to change that behavior? How can we change the environment to help change people's behavior? When we change the environment, we're shaping that behavior of everyone in that environment, meaning this is a universal strategy that reaches the entire population. If you remember back earlier, this would be considered an indirect activity. Again, those indirect activities only contain one-way communication between the prevention professional and the focus population. This environmental approach is divided into 2 subcategories, and the difference between those is that one of them centers on legal and regulatory initiatives, and their other one relates to the service and action-oriented initiatives. So that may sound kind of confusing, but you'll see in a little bit how that works. The legal and regulatory items really look at modifying systems, creating or updating policies and laws, things like that. The service and action-oriented activities look at changing community norms and some of those unwritten standards, or changing access and availability of alcohol, and it will try to change the attitude that influences incidence and prevalence of behavioral health problems. In our case, those problems would be alcohol, tobacco, or other drug use. The second subcategory is related more to the compliance and enforcement part of laws and policies. All of that put very simply, these 2 subcategories of environmental approach come down to compliance versus policies or laws. The distinction between these 2 is crucial when talking about environmental approach strategies. There might be laws or policies on the books already, but if those policies are not enforced, then they're kind of worthless. The next several slides will show the distinction between the 2 and which activities will fall under either one of these categories. In this strategy, it's important to focus on both, not just one or the other. We can create all the policies we want, but if current policies aren't enforced, then it's not going to be effective. Of those activities listed on the screen, they all have to do with compliance of underage drinking laws. So ATOD compliance checks are an activity that deters alcohol and tobacco outlets from selling alcohol to underage youth. And this can also be applied to marijuana in Montana as well. Law enforcement officials, usually they will supervise an undercover youth who attempt to purchase alcohol. If the attempt is successful, the individual who made the sale is penalized through a citation to the court. There's also another side to these as well, because law enforcement can send those citations to the Department of Revenue's Liquor Control Division, where that license holder can also be penalized through administrative rules being broken. For compliance checks, they do have best practice guides, and those usually will include how to conduct the checks, but some other considerations as well that will help prepare for the checks and some other follow-up tasks after the checks have been completed. Party patrols are often referred to by law enforcement as controlled party dispersal plans. They are aimed at party hosts and guests to deter them from participating in underage drinking parties and sometimes where they would create a public nuisance. And the goal is for the potential hosts of these parties to perceive a great enough risk of receiving a citation for hosting this event that they decide not to. North Dakota has a party patrol implementation toolkit, and in that it says there are 5 goals of party patrols. To 1, contain underage drinking participants in party situations, which could be a home, field, campground, etc. Administer preliminary breathalyzer tests, process citations if issued, identify adult providers of alcohol, and lastly, arrange for safe transportation of youth. Shoulder tap programs are typically used a lot less than the first 2 activities that I just mentioned. These are when law enforcement agencies use underage youth who stand outside of an establishment that sells alcohol, and that youth would ask adults entering the store if they would purchase alcohol for them. Anyone who does end up purchasing the alcohol and gives it to the underage youth is given a citation. Tip lines are also another tool utilized by law enforcement, providing concerned community members with an outlet to call and anonymously report illegal activities or provide other information about a crime that has already been committed. And the best example I can give for this would be something like Crime Stoppers. The last one, court monitoring, I think it's one of the most underutilized activities, and I think it's because many people may not be familiar with it. Court monitoring is a process where a prevention professional can gather information on court practices and procedures, how many citations are issued for alcohol-related crimes, and if those citations are carried through the court system as is, or if they are pled down. And there's some other just observations you can make. They would use this information to improve areas where citations might be lacking, or if there's specific citations that are constantly being pled down to lesser charges. An example of this might be reviewing law enforcement citation records for driving under the influence tickets written, and then comparing that to DUI convictions coming out of the court. If there's a lot that are pled down, that could tell you, okay, what is happening that these are being pled down? Is it a lack of information being gathered? Is it procedural errors? What is happening that we can help improve? One of the counties that I worked in previously did exactly that, and they found that some of the officers weren't writing all of their reports correctly for DUIs, so the conviction rate ended up being a lot lower because the prosecuting attorney didn't have what they needed in the report. So the individual in charge of this program, the court monitoring, they hired someone to come in to help law enforcement officers write those reports, making sure that they were following the procedures to help get a higher conviction rate. So that would be an example of court monitoring. Policies. The first thing I want to distinguish when talking about policies is there's a couple different types. We sometimes refer to them as big P or little p policies. Big P policies would apply to the laws and ordinances like a county social host law, zoning laws where marijuana retailers were allowed to have stores or not. Those things are written into code, whether on a local, state, or federal level. Little p policies are more local and individualized, and this might be something like a retailer policy that requires employees to check the ID of every person, or a policy that restricts happy hour drink limits, stuff like that. Those are local establishment policies. So looking at the first activity on this list, ATOD policy advocacy, enactment, or implementation. It can include both these big P and little p policies. The examples you see there are mostly related to laws because they deal with taxes, advertising, and outlet density. But it can also include a number of options besides those listed in the bullet points. With these, it's not always the absence of a law or policy, even if it's being enforced. Sometimes the laws and policies need to be updated to reflect the ever-changing landscape of alcohol and now marijuana retailers. Almost every single legislative session in Montana, there are dozens and dozens of bills introduced that have to do with alcohol and now marijuana laws. So things are always changing and constantly updating. So that's even something you could do under this activity, is just updating what those are or should be. The best place to start with any of these activities is by conducting an assessment of current laws and policies that relate to alcohol, tobacco, marijuana, or other drugs in your county, city, or tribal government. See what's in place before going and trying to make changes. The next two activities on this list are fairly closely related. When I started in prevention, there were no laws or administrative rules that said people who sold alcohol needed training. Fortunately, that did change a couple years later after I started. So now any person who sells or serves alcohol and their managers need to go through beverage server training. These trainings can be offered in person by people around the state, implementing the Your Community Matters curriculum developed by the Department of Revenue, or they can take an online class that has been approved for Montana. The goal of these classes is to prevent the sale of alcoholic beverages to underage youth and intoxicated persons. So you can find those resources on the Montana Department of Revenue website. As I mentioned, alcohol sales at public events are closely related to beverage server training. These public events it might include a fair or a festival, a street dance, a lot of community events, especially they happen in the summer. There are several things that can be implemented to help reduce youth access to alcohol. You could do things like having wristbands, ID scanners, alcohol-free sections, and also mandating that people selling alcohol are trained in a server training program. Here is where it gets tricky. If alcohol being sold at these events uses an alcohol license's catering endorsement or an off-premise sales license, the people selling and serving are often employees who must be trained. However, if individuals are volunteers that are serving under a special permit, legally they do not have to be trained. If we can get all these things implemented into a policy that could be used by the fair board, or the sheriff's office says you have to have these things before I'll sign off on your special event permit, we can ensure that no matter who is selling or serving alcohol, that there will be things in place that will reduce youth access and prevent overservice. So, like I said on the last slide, the best place to start with any of these activities is to conduct an assessment of current laws and policies, see what is happening, see what's already taking place. The Neighborhood Watch program would be considered a little p policy, where a group of citizens that are living within a similar geographic area get together to increase neighborhood safety. And while many do this in a formal fashion, it would not be considered a policy per se, but it does create environmental change. So this group acts as a deterrent to reduce the crime. And depending on the area, some do work with law enforcement, but others do not. And some pieces of this may just include education on safety and security to those living in the neighborhood. So it could be a variety of things. Lastly, school policies as they relate to alcohol, tobacco, and other drugs. This is another one of those that needs to be updated often, depending on drug trends, because couple years ago, we wouldn't even have had vaping in there, but now vaping is a huge problem. So many school policies have needed to be updated because of that. To work on this activity, the prevention specialist could review the policy, and if they have a relationship with the school administration, talk to them about areas where they might see room for improvement. Is there a student-athlete code of conduct? Are there policies and procedures in place if a student is caught with alcohol or drugs on school property? Or if a student comes to school and is suspected of being under the influence, all of these things can be included in a policy. That way, when they arise, there's a policy in place, procedures to follow, and it's the same for each student and leaves the guesswork out of it. I will say most schools have policies in place for these sorts of things, but as a prevention specialist, you can always review them to make sure they're up to date with current verbiage and trends from the field. Like I said, vaping was not an issue 10 years ago, and it may not be listed in the policy manual if it hasn't been updated in that long. So many schools do update their policies to include language of current drug trends. So to find these policies, usually they will have them on their school website, but if they do have one, it's usually on the Montana School Board Association's website as well. On the screen, you can see these tables that have all of the environmental approach activities listed in the category they fall under, whether they are compliance or policy related. So take a minute to review these. The last of the 6 CSAP strategies is problem identification and referral, which is considered a direct strategy because it involves two-way communication with that focus population you're working with. Of the 6 CSAP primary prevention strategies, this one causes the most discussion and controversy because it appears to cross over from primary prevention into intervention and treatment. This CSAP definition we'll review on the next slide precludes services designed to determine if a person is in need of treatment. However, a prevention screening to determine if behavior can be reversed through prevention education is allowed. A key aspect of this strategy is that the services or activities are geared towards behavior change. They are not therapy for alcohol, tobacco, or other drug-dependent treatment. These PIR activities focus on changing an individual's behavior through activities, services, or education, again, not therapy or treatment. And one of the most important things to note is that this strategy does not include actual assessments for treatment services or any activity designed to determine if a person is in need of treatment. A good way to summarize this is that we want to set up systems to make sure these referrals are in place and not actually making the assessments to make the referrals. So we're looking at systems getting set up and programs getting set up so these things can happen by someone who is a professional that's licensed to do those things. As the definition says on the screen, the activities in this strategy look at identifying someone who has inappropriately used alcohol, tobacco, or drugs, and whether or not they will be served by primary prevention services or education. As a reminder, primary prevention focuses on changing people's behavior to keep them from using substances. That's why we use information to educate them. We provide them classes to increase their skills and knowledge, to build resiliency. We have positive activities to keep them away from negative behaviors. We make changes to the environment to shape their behaviors and choices. PIR does not include services designed to determine if a person is in need of treatment, as I mentioned before. In the treatment world, those are called assessments, where it's determined if a person is in need of treatment, further treatment or not. And it can be confusing because there's a very fine line between some of the activities in this strategy that might seem like they're leaning more towards treatment, which is, again, why it can seem confusing. We'll go through the activities and define them a little bit more so you can see where that line can be drawn. So as a quick reminder, PIR is a strategy aimed at individual level change, which is why it focuses on the selective and indicated populations. Selective are those who are at an increased risk of developing a substance use disorder, and indicated are those already using or engaged in other high-risk behaviors. On the continuum in the picture, you can see how the indicated portion of the prevention section is right next to the case identification in the treatment section. Once an individual crosses into the treatment side, primary prevention is hands-off, and most funding guidelines for primary prevention do not allow any sort of treatment, anything like that. Sophisticated education programs is perhaps one of the most confusing for preventionists because in many places this class is taught by treatment professionals. So why is it an activity for prevention? Because it's an education course designed to change a person's behavior. One of my former employers was an outpatient drug and alcohol treatment facility where we held these classes. If an individual received a DUI, they were referred from the court for the Prime for Life class at my office. A counselor would do a quick intake meeting with the participant so they could attend the class. It was not a full assessment. The person who took the 12-hour education course then completed an exit interview, and at that point, it's still just the education program. However, if at the end of the course, the facilitator who taught Prime for Life determined the participant needed anything further, they were referred to a counselor to complete a full substance use assessment to determine what level of treatment they might need. This is where most of the confusion lies because in my prevention world, all of that was conducted by treatment professionals. So how can we work on this as a prevention activity? We can work to ensure that these education programs are available in our communities, help them get set up if they aren't available, and work with the court system to ensure that every person who is in need of an education course receives the appropriate referrals. This may seem simple, but it's not always happening when it should be. So this is definitely something that you could work on to help get implemented. Another great way to make available education programs that are designed to change the behavior of underage youth who have been enrolled in juvenile probation or a youth court. We know from risk and protective factors that youth who have higher risk factors such as delinquent behavior are more likely to use substances and develop substance use disorders. So if we work with the probation and court system to intervene earlier, we can potentially reach these youth before they use substances, or if they already have, provide them with evidence-based education to change their behavior from becoming worse. The great thing about working with these two activities is if there is a youth treatment court within the county or reservation, they have partners they work with who can get an assessment done quickly and further enroll the youth in the programs they need. If you don't have a treatment court, juvenile probation and the local courts are still great partners to have on your coalition or group of stakeholders that you work with, even if you may not be working with the teen courts on your action plan. So still someone to be a good partner. Employee assistance programs are designed to help employees with personal problems that can affect their job performance, and they usually cover a whole host of services and referrals. In the context of prevention, EAPs provide substance use or abuse information to people whose substance use related problems might be interfering with their work performance. What's also great about these is they are often part of health insurance plans. So if an employee's family members are enrolled in health coverage under their employer, that family member is eligible for EAP services as well. Some employers also have to adopt a drug-free workplace policy, and EAPs are part of this as well. On the screen, I have included a couple components of each program or policy, and you can see how they might complement one another. So take a moment to review those. For larger companies, this might be something that a human resources department would do, but think about those small businesses in Montana that might not have these. This might be done on more of an informal basis, if at all. If a company is large enough, they might have their own in-house EAP, but most companies that do have them use external resources for their employees. There's also other types of programs, such as those blended between internal and external. member assistance programs, peer-based programs, and several others. And I will say that SAMHSA's website does have something called EAPs and drug-free workplaces. They also have an EAP prescription drug toolkit and fact sheets. So those would be worth looking into. Along the same lines as employee assistance programs are student assistance programs. Essentially all the things as an employee assistance program, except for its youth in a school setting instead of adults in a workplace setting. SAPs focus on the non-academic barriers that may prevent students from fully benefiting from their educational experience, and we can tie these barriers back into some of those risk and protective factors in those peer and individual domains and the family domains. Things that happen within their group of friends and possibly outside of school at home can interfere and create barriers for student school success. The items on screen are general goals of an SAP. Some other things included in an SAP not listed on the screen is school policy development to support that SAP, follow-up services at the school or in-school services like support groups. SAMHSA does have this really great resource guide to help with student assistance programs, and I encourage you to go research online and find these workbooks for more information. The one on the right is specifically for school administrators and prevention professionals looking to help implement student assistance programs should take a look at both of these resources before they begin this activity, but they are both very, very helpful. Knowledge check. True or false? The prevention education strategy is considered an indirect strategy. True or false? Information dissemination has both direct and indirect activities. Which of the following is not considered an activity of problem identification and referral? A. Student assistance programs, B. Community mobilization, or C. Teen courts? Which of the following is not considered an activity of prevention education? Drug-free social and recreational activities, cultural programs, or parent-family management services? Blanks. The 6 CSAP strategies are to a close. My hope is that you have a better understanding of all 6 of the strategies and what they mean. They can apply to all types of audiences, all types of populations, but there are different strategies to choose depending on if you're focusing on population level change, which are those indirect, or individual level change, which are those direct activities. The great thing about using these strategies together is that you can have a mixture of both options, and taking it further, applying those activities within multiple contexts of families, schools, individuals, or communities to create the most change. We'll continue building on that concept in section 3. We're moving on to our last section, section 3, how to effectively use those CSAP strategies. It is broken down into these 3 categories. We'll talk about what evidence-based prevention looks like in Montana, which I've covered a little bit in the previous sections and mentioned a few things here and there, how to choose those strategies, and then we'll go over how everything comes together to build a comprehensive plan for the community. This will include several examples of how to leverage strategies with one another. Sections 1 and 2 serve as a foundation for section 3, where we'll use the pieces we learned in those sections and then build even more and start deciding what and how to choose programs for our logic models. Prevention science tells us using as many or all 6 of the strategies has the greatest potential to reduce and prevent substance use by reducing those risk factors and increasing protective factors. We've mentioned that theme over and over throughout this training, and the more we use these strategies and evidence-based programs, the more effective we're going to be. So what does that look like? How do we accomplish it? We will consider levels of effectiveness, conceptual, and practical fits as we go through that. This definition on the screen is what it means to do evidence-based prevention. The Pew Charitable Trust has a report called How States Engage in Evidence-Based Policymaking, a National Assessment. And that report states, by focusing limited resources on public services and programs that have been shown to produce positive results, governments can expand their investment in more cost-effective options, consider reducing funding for ineffective programs, and improve the outcomes of services funded by taxpayer dollars. This aligns with what we hope to do with our prevention funds to make the greatest impact using the small amount of resources that we do have. How do we find these programs? What should we look for? Answers to those questions will begin on our next slide. To understand how to use the strategies we reviewed in Section 2, we also need to discuss the levels of effectiveness. We're using these strategies together to make change in our communities. We want to make sure that we're spending our time, efforts, and resources on activities that we know will be effective. The definitions on the screen come from the Montana Evidence-Based Work Group. The work group's purpose is to assist prevention specialists and coalitions with identifying research and evidence-based practices that are grounded in prevention science, and if implemented with fidelity and they are culturally relevant, they can achieve measurable outcomes and move the needle on curbing and addressing substance misuse and abuse. That work group is currently working on setting criteria and guidelines for local prevention specialists and coalitions to help them develop a prevention strategy that meets these evidence-based standards. A program's effectiveness must be supported by one or more of the resources. They must be included in a national registry of evidence-based interventions. They must be reviewed by an established evidence-based program evaluator. They might be published in a peer-reviewed literature or a journal, or they have local community data indicating the successful results from implementation. So there is an online guide called the Guide to Evidence-Based Work Group, and that is on the Montana DPHHS website. We have effective programs, which means multiple studies have been conducted and found that that program is effective at reducing the problem behavior over the long term. For promising programs, they have some evidence of effectiveness at reducing a certain problem behavior, but there is more studies that need to be done to evaluate the effectiveness of that program. Those innovative programs are those that they have very limited research. If there's multiple studies done, they may have seen different results from that evaluation of the program. So these are just a brief overview of what these are. It's just enough to familiarize yourselves with the definitions since I mentioned them several times throughout the training. There's another level that's not listed on this slide, which is the not cleared list. Programs on this list are those that do not have up-to-date research regarding their effectiveness, or the research indicates that there's no statistically significant effects. Last note I will say for this is that there can also be harmful programs, meaning they have been shown to increase problem behaviors. Familiar with some of these lists where different evidence-based programs can be found, I've included a picture of a few of them on this slide. Blueprints for Health Youth Development, as I mentioned previously, I've used it a lot. It's definitely a favorite of mine to use because it really is the gold standard of program lists. The others are also very good too. Further into our primary prevention world of evidence-based programs, the evidence-based work group has also taken it a step further to dig into the lists and clearinghouses I mentioned on the previous slide to examine and determine which of these programs, policies, and practices would be effective in our state. Also, as I mentioned previously in another section, the evidence-based work group was also behind that culturally informed program book. It was in section 2. I mentioned that when we were talking about prevention education. So on the screen, you'll see links to both of the dashboards, one for the programs, the others for policies. What you can find on the program dashboard is a list of programs that are appropriate for use in Montana. At this point, we can begin looking on the program dashboard for certain programs and maybe what protective factors are affected by communities that care. What is the target population of the mental health first aid program? What domains are listed for the PACS tools program? This is where all of what we've covered in section 1 comes together. We're looking at, are we reaching the universal, selective, or indicated populations with this evidence-based program? So really the whole point of showing you these dashboards and locations and different types of programs is so you can start to choose which strategies and activities and specific programs within those activities are going to be most effective for the population that you're trying to work with. I always try to make to the prevention specialist I'm training is that although the grants we work under are very prescribed as far as the problems we focus on, they do tie to the bigger picture of the Montana State Health Improvement Plan. In fact, the mission of the State Health Improvement Coalition is to protect and improve the health of every Montanan through evidence-based action and community engagement. Their first guiding principle is to use evidence-based strategies to address health priorities. The first priority area is behavioral health, which is where our substance use prevention efforts fall. I do like to point out that the work we're doing does tie into that bigger picture at the state level, which always makes me feel like I am making a difference and that I am part of that solution and the greater collective making lives in Montana healthier, more productive, happier, etc. So now that we've looked at the type of evidence levels and the resources to find appropriate programs for Montana and our communities, we'll move into how we choose those that are right for our specific communities. If we bring back these 2 diagrams from section 1, this is where we start, which is why we went over that in section 1 to help build that foundation. When looking at our identified data, we ask ourselves, in what population does the problem exist? If you're working under a grant, the grant probably outlines what your problem behaviors should be, but still, the problem exists within a specific population. We next ask ourselves, in what context does this problem exist? Looking across the social ecology at these different domains or contexts, same thing. The problem exists. Does it exist in the community or the environment? Within the school or the family, or within their peer and individual groups? Where does this problem exist? This will tell us which risk and protective factor to focus on, which helps explains why the problem is happening. That's why the risk and protective factors are so important, is it gives us that why. When we know the why and the context of where it's happening, that gives us what we need to identify the potential programs, policies, and practices to choose, because each one of those programs, policies, and practices, they have that context or domain that works to address that problem. They have that population that this program helps to address and fix that problem. So that's how all of this ties together. So, for example, if it's a risk factor in the community domain, we might pick an environmental policy that reaches the entire indirect universal population. If there are low protective factors within the family domain, we might look at evidence-based programming for parents or families. So can you see where all of these things begin to tie together to help us choose which programs, policies, and practices, and therefore activities and strategies will work best for the population and context in which our problems exist? So as we build those logic models and action plans, we start to put together a picture of how we can address the problems in our community in multiple contexts. So think about it, in each of those examples that I gave, we can do that multiple times for multiple contexts, multiple populations. And when we do this, we're reaching as many populations as we can. We can reach that universal, selective, and indicated all within different domains. Instead of just focusing on one or the other, we're utilizing the knowledge that we have, that we've built across multiple domains to create the largest collective impact. So based on all the information that we went over on the previous slide, it's not just as simple as saying, let's pick an activity for each strategy. That's not how it works. So the activities must be tied to data, meaning choosing evidence-based strategies for specific populations, focusing on specific risk and protective factors that will affect the problems that we've identified. Unfortunately, not all strategies and activities have evidence-based programs, policies, or practices. So we do start with those that we know and that what we have, using places such as blueprints or the Montana dashboards to help us identify effective programming that we can use on our logic model. And if we are doing true community-driven work, we share our knowledge and expertise in these areas with our coalition members, with our partners and stakeholders, and as a group, we make a decision on what to choose. And also remember to keep the focus population in mind, as they should be involved too. What is going to work best for them, and what's going to work best for your community based off of feedback from that community. The course is meant to be just a refresher on some of those strategies, activities, how it all works. SAMHSA did put out this 40-page document titled Selecting Best Fit Programs and Practices, Guidance for Substance Misuse Prevention Practitioners. I would highly encourage you to look through this, and in this booklet, they go over many of the same concepts that we've reviewed in this presentation, but there are definitely some other things that should be taken into consideration when you're selecting your strategies, which make sure they are a conceptual and practical fit. So at this point, I'd like you to take a minute to review that portion of this manual by clicking on the SAMHSA on the screen. Read pages 5 through 7, and starting on page 5 at the header that reads, The Search, Finding and Selecting Prevention Programs and Practices. And once you're done with that, you can return here. At this point, we've reviewed the science behind the strategies, how we should place them together, and where to find effective programming. We come to the part where we want to know what this all looks like from a comprehensive standpoint. So looking at this diagram, we can see how the strategies can work together to create both individual and community level change. This is only one diagram that shows how it can work, but doesn't necessarily mean that all plans will look like this. This is just an example. But to be a comprehensive plan, they have to do 3 things. The first one is they have to address different levels of risk, which you can see in this example because they all have strategies that are both direct and indirect. The direct strategies of prevention education, alternatives, and problem identification and referral could address those higher risk populations, such as selective and indicated. The indirect strategies of information dissemination, community-based process, and environmental would all be for lower risk populations, or indirect, because they reach the whole entire population. The second thing, comprehensive plans also operate at different levels of influence, meaning they influence different populations. The third thing, lastly, they require the support and participation of diverse stakeholders. This should take place within all of these strategies in order for them to operate correctly and be community-driven. And one last thing to note is that, yes, we should do all of these things and hit multiple contexts, multiple populations, but with the resources that we have, sometimes that's not always possible, which is why it's, again, important to work with your coalition or other stakeholders, other groups in your community, so you guys can work on those shared risk and protective factors. You might be able to do some things, some strategies, some activities, and you can't do everything, but one of your partners can work on something else that also is similar to one of the risk factors that they're working on. And it may be similar. So those are shared risk and protective factors. And so just because you can't do all of them, which you shouldn't be to do them effectively, you would need a lot more time than you already have. You would partner with others in your community who also work on those same risk and protective factors and other behavioral health providers. So now I'm going to share a real life example of how these strategies can work together. And this is perhaps one of my favorite combinations because I've overseen its implementation several times and heard amazing stories. So for the environmental approach, I'm going to select alcohol, tobacco, and other drug-free policies for schools. If we remember from section 2, this activity entails reviewing school policies and working with the school administration to update them according to current alcohol and drug trends, things that they're seeing in the school. And it will include some sort of education component for students who are caught using substances and fill in any gaps where it relates to alcohol, tobacco, or other drug use and the school policy. For the problem ID and referral, I'm going to choose the Student Assistance Program activity. And this program usually lies within that school policy where there's a system set up for students who may need extra assistance in the areas of behavioral health and where the school has a plan to address these areas. This might include in-house items in the school, such as meeting with a counselor on a regular basis or taking that education course I had mentioned, or it could include, and usually I would say this would be the best case scenario, an outside referral to an agency for the student to receive a mental health or substance use assessment or evaluation. All of this depends on the school's available resources and capabilities. And I'm going to tell you a story about how these two activities worked together and how these strategies work together and provide a powerful example where they can truly make a difference and where you see this difference. So I want you to think, in a very small frontier town in Montana, a prevention specialist was hired. They had a passion for helping people, as most prevention specialists do. She dove right into the job, and both of these activities that I mentioned previously were on her logic model for her county. She was bold and courageous and came right out and contacted the school to see if the superintendent would be willing to work with her on reviewing that school policy to look for areas of improvement. This school was traditionally underserved without many resources, and there was only a couple dozen kids in the whole school district, so it often got overlooked. Thankfully, the superintendent recognized the help that this prevention specialist could bring and agreed to looking over the school policy. Together, they reviewed the policy, and she explained what a student assistance program was and gave him the manual that SAMHSA provides that I showed in the last section. He loved the idea of the student assistance program and wanted to move forward with it and recognized the dire need of his students that see how this student assistance program could help them. The prevention specialist then assessed the students and staff through a survey to see what they thought were priorities in their school. They came up with bullying, mental health, suicide, and marijuana as the top needs to be addressed. The prevention specialist got on this right away and discussed with the superintendent how they could address these problems. One of them, he agreed that having a question, persuade, refer, or QPR suicide prevention program presented to the teachers and staff during an admin day would be a good first step. And then past that, he wanted to present this same suicide prevention training, which was age appropriate, to the students. The prevention specialist then sought out a professional to deliver the QPR training to staff and then started working to develop a policy and procedure for a student assistance program, which handled how staff would respond to a student who was in suicide crisis, because previously they had nothing in their policy about how staff would address that. The prevention specialist also worked with the agency they worked for, who provided mental health and substance use services, to create a referral form specifically for that school to that agency. This ensured the process that the agency followed was reflected in the student assistance program the school used. So everyone's working together, everyone's on the same page, and the school now had a referral system set up in place for students. So the prevention specialist did all this background work, did the training for the teachers. About 2 months later, the QPR training was provided to students. It was very, very well received, and the prevention specialist heard great feedback from the students and teachers. This is where the story ends, right? And as a prevention specialist, sometimes that is where the story ends, and we don't hear a lot after the fact, after we deliver some of our interventions and activities. However, unbeknownst to that prevention specialist at the time, a student approached a teacher a couple of days after the QPR training that the students received. The student said, "We just took that training on suicide prevention and signs to look for, and my friend has said a couple of those things that we learned about in that training, and I'm worried about them." The teacher then thanked the student and took over from there. Because the school had this student assistance program set up and a referral system in place, and the policy was in place of what to do when this sort of thing happened, the teacher talked to the school counselor, who then talked to the student and their parents, and that student was seen by a mental health counselor the next day. So because of the work this prevention specialist did with the school using evidence-based policies and practices, she potentially saved a life. After about a year of the SAP being implemented in this school, it wasn't just that one. There have been almost 10 students referred to mental health or substance use evaluations because of this system that was set up in place by prevention through this policy, through the student assistance program. And I think this story is so powerful, number one, because it saved a life. And oftentimes, like I said, we don't hear in prevention the impact of our work all the time, but this was an example, and I use this story often to show that a life was potentially saved because of the work that a prevention specialist did. So this is just one example of how these strategies and activities can work together to make a significant impact in a community, especially a school of that size with 10 referrals in a year, and there's only a couple dozen students in the whole school. That's a very, very significant impact that prevention had. Thinking back to that example, using the same school in the story that I shared, the prevention specialist knew addressing the overall school environment through policy and targeted referrals were not enough. So while it made a huge impact, she wanted to do more and increase the knowledge and skill sets within all the youth in the school. So it wasn't just about getting that referral system set up in place. Our job is prevention. And what else can we do to prevent youth from being in that situation in the first place? By increasing those protective factors, increasing their knowledge and skills to be able to resist peer pressure or resist negative influences in their life to want to use those substances. So she again worked with the school to add in an evidence-based program using one that was on the Montana Evidence-Based Program dashboard. The program they chose had outcomes that matched what the kids said in that survey she gave them that needed to be addressed in their school as far as mental health and bullying, and also some of the risk factors that were identified on the county logic model. So now, in addition to environmental and PIR, she was using prevention education. So she's using 3 of the 6 strategies, and she kept going from there. It didn't stop at just those 3. To the contexts and domains in which prevention can take place and the different populations we reach. If we think about that prevention education program, it's being done in the school setting for that peer and individual domain. And then if we think about that policy as well and the student assistance program, that also is taking context within the school and peer and individual domains. So we're hitting those pretty hard, but we want to be most effective, and to do that, we need to add another strategy that reaches another domain. So the prevention education and PIR, those are hitting the direct populations and selective populations, or even indicated. And now we need to look at something that's universal. We know in prevention, using all of these activities together is going to create the most impact. So building on to those 3 strategies already used, that prevention specialist added another one. One of the things that school staff and administration identified in the survey that was conducted with them, one of the things that was identified as being a big issue with families is what they were hearing from their students about parental attitudes favorable to drug and alcohol use. Students were saying things like, "My parents don't care if I drink alcohol as long as I'm not driving." And I've heard that in my prevention career many, many times. One student even said, "My parents don't want me taking medication for my ADHD, so they gave me marijuana to use instead." This is true real-life stories heard from students by these teachers. So those issues were dealt with directly between the school and the parents, which is good. But using that qualitative data paired with the risk factor of parental attitudes favorable to drug use from the Montana Prevention Needs Assessment, it was decided that the best course of action was that information needed to be shared directly with parents as well as the general community about youth substance use, why it's harmful, and give parents the tools of how to talk to their youth about substance use. So they went to SAMHSA because SAMHSA has a pre-done media campaign called Talk They Hear You. Looking at this example, I want to demonstrate how this comprehensive plan is reaching multiple contexts again and multiple populations, which we know is the best way to create an impact. So again, we are using that population strategy of the information dissemination. We're reaching the whole community and the parents and making sure that those messages are being shared. So the same county is also using community-based process to create movement and collaboration within the county, which is also incorporating positive alternative activities for youth. So some other things are happening there that hit other activities, which if you remember back to when I talked about shared risk and protective factors, there are other agencies that are also doing those things. So the prevention specialist may not need to necessarily focus on those because it's happening with other entities in the community, but they can definitely work together to make sure that everyone's on the same page. We're all working towards the common goal. So all of these examples that the prevention specialist did with the school and the other work within the community are reaching all 6 of those strategies, and that is going to create a tremendous impact, obviously currently with those youth whose lives are being saved because of that training and those referrals, and down the line long term because they're building skills and resiliency in the youth and the families. Again, to summarize that example, we're using multiple strategies in multiple contexts to address multiple levels of risk and are using multiple stakeholder groups to make that happen. What else do you think we could add to this plan? What about a parenting class to increase the knowledge and skills of parents to talk to their kids about alcohol or drugs? Not just a media campaign or direct contact with them about the SAMHSA Talk They Hear You. It might not be enough to share the information with them, and we might need to teach them how to do it and help them understand why it's so important to share this message with their kids. And how do you think we could add more community support for the school, which involves more stakeholders? What about getting youth-serving organizations like the Boys and Girls Club or a local religious group to host an after-school program with positive activities? Those are the sorts of things that other community groups could do. In rural and frontier areas, this probably will be more difficult to implement, but could work if they did it maybe one day a week. You never know unless you ask. Either way, we're going to be adding more strategies and activities. And if we're doing that, we need to have support from all community sectors to make that happen on a broader community environmental level. One of the most important things we need to also think about is that last bullet point of evaluation. It would be a huge mistake to leave evaluation out of this process. And if we're following the strategic prevention framework, obviously that's a huge piece of it. At this point, we've chosen strategies and activities to implement, but I want to highlight how this evaluation is important to the whole process and what we should be evaluating. The short answer to that is everything. The bullet points on the screen demonstrate process evaluations, meaning is the activity being implemented as designed? Is that policy being followed that the school implemented? Are the referral services being made? If not, why not? How many students are receiving the prevention education classes? Are the classes geared towards one grade, another grade? Is every student in that grade getting them, or is it the whole middle school? If you're using that evidence-based program, is the program being followed to fidelity? Meaning, are you implementing it exactly as the program has been designed? And lastly, is the message to parents resonating from that SAMHSA Talk They Hear You campaign? It's not just measuring the number of ads you ran or articles in the paper you ran or how many brochures you handed out. Are the parents receiving that message? Is anything changing? And what sorts of things are the parents saying about it? Like, I don't really identify with this. I don't think that applies to me. So those are all process evaluations to make sure that everything is being implemented as it should be. To find that out about the parents, you could possibly do a focus group with parents or the community members to see how they like the campaign or see what improvements they might need to make to that to make it more suitable for your community. Now for moving to outcome evaluation, we want to ask ourselves, has the combination of these activities and strategies helped reduce our targeted risk factors and problem behaviors? Have behaviors improved for the positive? If yes, that's great, amazing, we should keep going. If not, why have they not improved? At that point, we might go back to our process evaluation to ensure everything's being followed as designed. If that policy is not being followed, then more than likely you're not going to see the long-term outcomes that you want. If the policy is being followed, if everything else is being followed and still hasn't achieved the desired outcomes, you might need to look at adjusting some of those strategies and activities. Example is a very, very good example of how all of these strategies and activities can work together. The strategies were used to support one another, which will create better health outcomes for all populations within that community. And the example I used demonstrates how each piece is used to create that comprehensive approach. It reached all risk levels, universal, selective, and indicated, and it utilized strategies and activities over multiple contexts in the community, family, school, peer, and individual. So it provided almost the best case scenario to try and see that change in the community. And lastly, most importantly, it collaborated with a variety of stakeholder groups to implement the plan. It got feedback from the teachers, from the students, if you did a focus group for the parents. It created that community buy-in, and one of our most famous prevention sayings is nothing about us without us, and it involved everyone in the whole process. For this knowledge check, match the evidence-based type with the correct definition. We have effective, promising, and innovative. To wrap up section 3, I want us to remember all of the tools we've learned in this section to use the evidence-based programs, policies, and practices as we select strategies to implement to create a comprehensive plan that will create the most positive outcomes we're trying to achieve in our communities. As you're creating your own logic model and plans of action in your communities, I encourage you to truly think about how you can use everything that you've learned in this course to tie your activities together and leverage them off of one another. There are so many options available, and really the opportunities are endless of what you can do to be effective. Many of the resources I shared throughout all of this training are listed on this slide, and these are all just general good resources anyways for different things that you're working on, some activities. Some are just general resources that you could use for your prevention work, but they are all very good. I have used all of these and I have found them extremely helpful. So I would encourage you to check out all of them. I want to thank you guys for spending time with me to review these CSAP strategies, how they work, how we use them, and I really hope that you gained something out of it. And please rewatch this at different points in your prevention work. You might find a different example or something else that might click with you. So please revisit this if you can. I hope you took good notes and have come away with some great ideas for you to implement in your own communities. Thank you.